definitions in here that I want you to know. And a lot of these you've learned before in previous lectures. We're gonna go back, so last week you had your Parkinson's lecture. Next week you're gonna be talking about personality disorders, and a lot of these terms are gonna come back to you, and you're gonna be seeing them again and again. So we're just gonna review some of them, and we'll talk about them all through the lecture. So, as far as extrapyramidal side effects, these are involuntary movements that are caused by antipsychotics. And some of these extrapyramidal symptoms, one is akathisia. Do you guys remember what akathisia is? Restlessness, right? Abnormal moving, like moving, pacing back and forth. Sometimes it can be like tapping your foot like constantly, but this like constant restlessness that you can't stop. Dystonia, you guys remember what dystonia? Yeah, so muscle, like an involuntary muscle contraction, right? And it can involve like a little twisting, it can be really painful. One thing that's scary about it though is it can involve like your laryngeal muscles to contract, and it can lead to respiratory distress. Tardive dyskinesia. Do you guys, somebody over here remember what that is? So that's like that involuntary, like mouth movements, like your tongue, the tongue moving around, lip smacking, continuous abnormal movements. That the problem with that is it can be permanent. Okay. And then how about pseudo-Parkinsonism? Shuffling gait, right? Maybe like pillow rolling, where their fingers are constantly moving back and forth. How about hallucinations? What are hallucinations? Yep, right. So perception that somebody believes is there, right? So it can be seeing something, hearing, smelling, feeling, like the person may feel like there's something crawling all over them, and that can happen just out of nowhere without something like stimulating it. How about a delusion? Yeah, so, right, kind of on the same idea as a hallucination, but this is a false belief, all right, and that the person really believes for themselves for it to be true. Okay, now there are 3 delusions that I want you guys to know. There is a lot of delusions when you look in a psych book that we can talk about, but there's 3 main ones, okay? Delusions of persecution, right, so somebody feels that somebody's always after them, right, maybe the CIA is out to get them. Delusions of grandeur, they believe that there's somebody way more powerful than they actually are. They may believe they're God. And what's the last one? Remember? Delusions of reference. Yep. So delusions of reference, the person thinks that somebody on the television is talking directly to them, like they're watching a newscaster and they're speaking directly to them, or they hear a song on the radio and the person is singing the song and it's about them. Okay, so then we go to catatonia. So catatonia is any abnormal movement or speech or lack thereof. So they could have mutism, which is a lack of speech, not being able to talk, or maybe an abnormal speech. So if you look at the word echolalia, so echo, right, it's repeating words. So echolalia would be repeating somebody's speech over and over. Echopraxia would be repeating somebody's movement over and over. How about waxy flexibility? Does anybody know what that means? Yep, stuck in the same position. So say you go to take somebody's blood pressure, you hold out their arm, and then you stop and they just leave the arm, right, like that. How about anhedonia? No pleasure, yep, inability to feel pleasure. Abolition, lack of motivation, right? They can't function, can't perform their own ADLs, don't have that motivation to get up and take a shower and get going with their day. How about psychosis? Yeah, so psychosis is a broad term, but any disconnect from reality that a person has. Waxy flexibility, sure. So waxy flexibility, Yeah, wavy, waxy. Yeah, waxy flexibility is when a person's body is stuck in like one position. Like you could hold their arm out and then they never put it down. They just are stuck in one position. Okay, so we're going to be talking about schizophrenia and bipolar today, and they are very similar. So a lot of the stuff we talk about is going to be grouped together. So first we're going to talk about risk factors, and they're generally the same. There is no definite test that says, yes, you can't do a blood test and say, yes, you have bipolar, yes, you have schizophrenia. So a lot of these are probable, and it's probably some combination of factors that can lead to either bipolar or schizophrenia. The biggest one is genetics. So usually if you have a family member with one of these, you have an increased probability. Twins, definitely. Epigenetic factors. So that means that maybe when the mom was pregnant with somebody, maybe she didn't get good prenatal care, something happened. The baby could have been exposed to an external virus or something that led to it. Economic and social factors, so rapid changes. So it's kind of like that snowball effect. There's a death in the family, then you lose your job, and then everything just kind of seems to get out of control all at once. A good example right now is like COVID, right? So people were secluded for a long time, and then they maybe lost their job, and then they weren't seeing their therapist like they normally did. And right now we're seeing like a huge demand and need for mental health care, okay? An unhealthy lifestyle, substance abuse can trigger it. Psychosocial factors, people that have a history of being like domestic violence or being abused have a greater risk. Personality factors, researchers have found that children that have cognitive or emotional delays are more at risk as well. And then there's definitely like changes or impairments in the structure and function of the brain. So when we do an assessment, a mental health assessment, first we need to make sure that the patient is actually able to complete a health history. They might not be in the right state of mind to answer your questions, so you're going to have to assess that first. If not, you can always go to the patient's healthcare proxy if you're not able to. You're going to look at their past treatments. Have they seen a mental health professional before? Past counseling services. You also want to check, maybe it's a cultural factor. Maybe they haven't seen a mental health professional before because there's like a stigma related to it. Maybe their family thinks that's taboo and that's not something that they should do. So you want to assess that as well. Look at their family history. Are they able to carry out their own ADLs? History, substance abuse, drugs, alcohol, and what's going on in their life. And of course, we're always going to ask about suicidal ideation. I'm going to talk a lot about that throughout the lecture. So when you look at the person, like, is the person able to make eye contact with you? Can they concentrate? Are they slumping over in their chair? Are they sitting up? Like, what's their posture? Are they all of a sudden really happy when you're talking to them, then really sad? You want to look at how they're dressed. Is it 95 degrees out, but they're wearing a hat and a coat? How appropriate are they? You're going to want to talk to them. How's their speech? And then observe, like, are they just talking in random? Do they have random ideas coming out? Is what they're saying making sense? So we're going to talk a lot about these interrelated concepts. Patients with mental health, they have like almost like a disconnect from self. And we're going to talk a lot about safety as well. Okay, so our exemplar is schizophrenia, right? It's a complex brain disorder that affects thinking, language, emotions, and behaviors, and the ability to perceive reality correctly. So when we talk about schizophrenia, is almost like a broad term. So have you guys heard of the DSM-5, right? And that's how psychiatrists, physicians diagnose mental health disorders. So when they diagnose schizophrenia, it's under this large block, and it's called schizophrenia, and other psychotic disorders. So we're just going to kind of talk about the broad schizophrenia of it. At the bottom here, I have schizoaffective disorder, which is basically a mix of schizophrenia and bipolar. And you're going to see that a lot of mental health illnesses, a lot of them do overlap. So you're never going to get a question of, is this bipolar or is this schizophrenia? Because it's really hard to discern. It's even hard for physicians to really figure it out. So when they do diagnose somebody, the first thing that physicians do is they rule out all of the other biophysical factors, right? So make sure they don't have like a fluid and electrolyte balance that's causing symptoms, make sure it's not an infection, make sure they don't have cancer, they're gonna do lab work. So when that all gets ruled out, then they go to that DSM-5, right, with all this little checklist, and they're gonna go and see, and then that's how they're gonna actually diagnose the disorder. So for schizophrenia, for a physician to diagnose that, they're going to have a checklist, and basically it's going to say, like, one of the terms is, have they had periods of psychosis for greater than 6 months and not able to carry out their ADLs or functions of daily living for 6 months or greater. And then there's going to be all different, there's like schizophrenia with delusions, schizophrenia with hallucinations, and they're just going to go through a checklist of that. So when we look at the pathophysiology, they do believe that patients with schizophrenia do have an increased dopamine in their system, and that's found by the meds that we give them, that they do have too much dopamine in their brain. And also there is some alterations in blood flow too. So before a person has it's not something you can scan though, so before a person has an actual psychotic episode, you could do a scan of their brain and not see anything. But if somebody starts and goes into a psychotic state and you do a CAT scan, you can see increased blood flow in parts of the brain, which is cool to see. Your book shows that, if you want to take a look at the picture of that. It is diagnosed in late adolescence or early adulthood, usually like early 20s, late 20s for men and women. There is something called early onset schizophrenia and late onset schizophrenia, and it gets a little confusing. Sometimes schizophrenia, like with having that disconnect from reality and not being able to function. For children, it gets sometimes like a little confused with autism and stuff too. So that's why they really have to go through that DSM-5, which the psychiatrists use. So I keep talking about how it affects a person's ability to live in society. But some people do, once they're on meds, get the appropriate therapy, they can be functional members of society. And I think it's really important for us as nurses to tell our patients that, because it can be really scary to get that diagnosis, right? Like, oh no, schizophrenia, I'm gonna need help the rest of my life, I'm not gonna be able to carry on a job or live by myself. But they can, as long as they get the appropriate treatments. Okay, so here's a picture of some common symptoms of or clinical manifestations of schizophrenia. And in no way does anybody have to have all of these going on. Usually it's a cycle of a couple, crying without reason. So that's that change in affect, laughing without reason. At the bottom you can see lack of motivation is a big one. So when we talk about the clinical manifestations, it's split up into positive symptoms, negative symptoms, and cognitive symptoms. So positive doesn't mean good, but in this instance, positive is the presence of something there that is not usually there in a healthy person. So we're going to have those delusions, hallucinations that we talked about. Psychosis, we have depersonalization and derealization. So depersonalization is when the person has that disconnect from self and that altered reality. So it's almost like they say, look, there I go, I'm walking down the street. There I am over there. Or maybe they might be like, look at my arm, can you see how it's growing? My arm is getting really longer than my other arm. And then derealization is that disconnect from the environment around them. So maybe like, look, everything's shrinking. Can you see everything shrinking? Or it's raining milk or something like that. Grossly disorganized thinking, speech, and behavior, so a flight of ideas, so just talking about a bunch of random things that have no connection to another. I went to work today, the sky is blue, my mom likes the color red, just a flight of ideas, and you can't stop them. You can't interrupt them from it. We talked about the echopraxia, echolalia, so repeating movements, the repeating of words. Clang association, does anybody know what that is? Rhyming, right? So they just might be going cat, bat, mat, hat, but it doesn't make any sense, no context to it. How about word salad? Yeah, just a bunch of words all put together. Same thing, doesn't go together, doesn't make any sense. Ambivalence, not being able to decide, not being able to make up their mind, not caring about anything, and then just like really just stuck on one thought. You cannot change, like you cannot get them off one idea, or you can't interrupt them. They're just constantly going, constantly talking. Negative symptoms. So negative is not having something that a healthy person would have. So they have this blunted affect, right? Maybe not showing any emotion, right? Not motivated. Social withdrawal, they keep to themselves. Not able to feel pleasure. Not being able to, keep their attention, stay focused on anything. And then finally, the cognitive symptoms, right? Really bad memory. We talked about poor attention, very concrete thinking, so there's no joking around. You have to like really, you can't be sarcastic with them. They're not going to understand that.
What was negative? Not having something that a normal person?
Yeah, it's the lack of something somebody has. Okay, so now we're going to get into the meds, all right? So what I have here highlighted in yellow is the actual meds that are on your CLM. So those are the meds that you need to know. Now, there's a lot going on with meds, but when we talk about the medications, you don't need to know like each one specifically. What you need to know is you need to know them in a group, okay? You need to know what they do like as a group. So the oldest meds right now, so these are called first generation, conventional, or another term is typical antipsychotics. So these are the real older ones. So these treat the positive symptoms. So that's why I just went over all those symptoms with you, all those positive symptoms, those hallucinations, delusions, these only treat those. And these first generation, conventional, typical antipsychotics, they're mostly given to patients that are very aggressive or have violent behavior, okay? So now, the problem with is they come, you can see this huge list of complications with them. So what we want to do is, when physicians order the medication, we want to start them on the lowest dose possible and increase it very slowly. We don't want to say, well, this person's having terrible hallucinations and delusions, let's just give them a huge dose. You can't do that. Okay, so the biggest, one of the biggest problems is those extrapyramidal side effects. So we just talked about them all. So what was one that we talked about? Dystonia, okay? So dystonia, remember that muscle contraction, right? So it can be painful, okay? So we can give them a med to help. Does anybody know what med we would give them? Benztropine, right? Remember you learned about that when you talked about Parkinson's? So if somebody is experiencing one of those extrapyramidal side effects, we can start them on that benztropine or cogentin, and they can take a daily dose of that. Now remember when we talked about dystonia, it can lead to respiratory distress, right? So say it can happen pretty fast. So you give a person one of these, they get their first few doses of the first generation antipsychotics, and then all of a sudden they start developing respiratory distress. We're not gonna say, here, take a benztropine, like they're not gonna be able to swallow. So we can actually give them IV benztropine instead. So you can get IV benztropine or IV Benadryl, and that'll help with that. All right, another extra pyramidal side effect we talked about, remember that akathisia, that restlessness? So for that, same thing, we could give benztropine, or they could even get beta blockers to help with that restlessness, or a benzodiazepine like Ativan to go with it. Same thing, remember they might develop those Parkinsonism traits, right, that we talked about. We'd give them benztropine as well. So it's our job as nurses to educate the patient to watch for these symptoms if they happen. So the problem gets a little tricky, so they start to develop these like side effects, but is it just their psychosis that's getting worse, or are they having symptoms due to the med? So that's when we do the Ames scale, and I'll pull up a picture of that after, and we can actually do a scale to figure out if their side effects are getting worse. Okay, they can also develop anticholinergic effects. So what does anticholinergic mean? Dry mouth, right? So have you guys heard the phrase, can't see, can't pee, no stool, no drool? Yeah, so that's how you're gonna remember all those anticholinergic effects, right? So when we teach our patients, so the first thing, right, can't see. So sometimes these meds, they can cause like a blurry vision. We just have to teach them, they're gonna have to be followed by an ophthalmologist. All right, so can't see, can't pee, right? So urinary hesitancy, so what should we teach our patients? So yes, they really need to stay hydrated. All right, so maybe just telling them always keep a water bottle with them. We all have our favorite like to-go water bottles. Maybe we can help them find one, but they always keep water with them. No drool, they're gonna have that really, really dry mouth, right? So those sugarless candies to suck on, having that same water bottle with them. So no stool, constipation. What should we teach them about that? Fiber, right? So now these patients, right, they might have some cognitive symptoms. So if you say, increase your fiber in your diet, are they gonna know what you're talking about? So we would be very specific. So what kind of foods are we gonna teach them to have? What's high in fiber? Yeah, fruits, vegetables, right? Again, with that increased fluid intake. Okay. Along with that, so we have neuroendocrine effects. So these meds can lead to remember gynecomastia, so enlarged breasts in males, menstrual irregularities. So there's not much we can do about that. We just have to tell them, make sure you notify your provider if that happens. Skin effects, they're going to be really sensitive to the sun. They need to wear sunscreen every time they go outside. Need to wear sunglasses. Orthostatic hypotension, right? So again, with that, increase your fluids, get up slowly from a lying position. Granulocytosis, what does that mean? You guys remember? Low white blood cells. So what do our white blood cells do? Fight infection, right? So before they start on these meds, we need to get a baseline white blood cell, right? Do lab work on them. We're going to have to do it periodically. And what we have to do is teach the patient, right? So if you have just even a minor sore throat, a minor fever, they need to call and let the provider know, because it could turn into something worse because they don't have white blood cells to fight their infection. It can lead to dysrhythmias, so they're going to need to get a baseline EKG and follow up with EKGs throughout while they're getting the med. And then neuroleptic malignant syndrome. Okay, so I think you guys touched on this a little bit when you did trauma. So this is a life-threatening emergency. Okay, so it can happen usually within a couple days after starting on these medications. And what happens is the person develops a really, really high fever and muscle rigidity. Okay. So usually, you know how we talked about like maybe if they develop these symptoms, we'll see, we'll add another med, maybe we'll lower the dose. If they develop NMS, we're gonna stop the antipsychotic. They are not gonna get it. And usually, and then from a nurse's point of view, then we're gonna send them off to the ICU. They're gonna be, the first thing we have to do is treat that fever, right? Giving them whatever Tylenol, whatever we can do, cooling blankets, and then giving them like a muscle relaxant, maybe a benzo, because they're gonna have some confusion, anxiety, to calm them down as well. So when I talked about what this med treats, it treats the positive symptoms, right? It took me like 30 seconds. I looked at the clock before I started talking about all the complications, and it took me like 8 minutes to talk about all the complications. Can you see how that would be a problem for somebody, right? Especially these patients that they don't have a good sense of self. So what happens is they're like, you know, I'm taking this med and I feel terrible. I'm not having any hallucinations or delusions now. Now I'm gonna stop the med. Okay, and that's the problem. And it's kind of a vicious cycle. And they forget that, or maybe they didn't even realize that they were having these hallucinations and delusions in the first place. So it's up to us as nurses to make sure that they're staying med compliant, and that we're teaching them really the importance of the meds and really trying to control all these side effects. And also, I mean, sometimes these patients, they can't even, perform their ADLs, so how are they going to remember to take this med, plus another med to control the symptoms, plus another med to control the symptoms? So it just kind of keeps going on and on, so we really need to help them with that. Okay, so now we go on to the second generation, or atypical antipsychotics. So like I said, the ones in yellow, they're all of them, they're all on your CLM, and we all have to, we're gonna just, combine them all. Abilify, that's a third generation, but we keep it kind of clumped in with the second generation antipsychotics, because it kind of does all the same thing. So these work a little bit better than the first because they treat both the positive and the negative symptoms, okay? So they're gonna treat the hallucinations, delusions, but then all those depressive symptoms as well. The problem with this one is it can lead to metabolic syndrome. So metabolic syndrome is, it can have new onset diabetes, right? Or if the person does have diabetes, it can lead to a lack of like glucose control. It can also lead to weight gain and hyperlipidemia. So our big focus with these meds is teaching our patients that they need to eat well, watch their weight, exercise. But if somebody already has diabetes or they have heart disease, we really aren't going to give them this medication. It's not going to be good for them. It can lead to sleep disturbances. We usually start it at night, so they'll get it start it before bedtime because it can make them sleepy. In the beginning, it's kind of like they fall asleep, they wake up, fall asleep, wake up. Usually that should wear off within a couple weeks. So these meds are better when it comes to all those extrapyramidal symptoms, anticholinergic effects, and neuroleptic malignant syndrome. We don't really have to, we want to monitor for them. It can still happen, but it's a lot less likely to happen. So these are more likely to be used now. One thing I didn't put on there, which I want you guys to write down, remember we talked about that granulocytosis. So they're still at risk for granulocytosis, but it's lower. There is a med that it's not on your CLM. I don't want to confuse you or anything, but I don't know if have you guys heard of clozapine before? Okay, so I'm not quite sure why we don't teach it here, but it's not used quite as much because it can cause significantly low white blood cells, to the point where it's even been banned in some countries, that they don't even use it, but it actually does work really well. So there are still some patients around here that use it because it works. The thing is there are very strict measurements on how we check their white blood cells. It's very often we have to check their lab work. The only reason I'm bringing it up is when I was going through NCLEX questions, that med does come up a lot. So just kind of, I know we're not talking about NCLEX right now, but just kind of file it in the back of your brain. So when you see clozapine, if you know second generation atypical, right, just put it in that category. We talked about all that. Okay, so here's the AIMS scale, right? I know it might be a little bit hard to see, but it is posted in your Brightspace with directions on how to use it. And by no means do you have to memorize it. I don't want you to know each category, but I do just want you to know what it is and what it's used for. So we do use it, we just want to test. Like I said, sometimes it's hard to differentiate. Is the patient exhibiting symptoms from their illness, or is it just from their medications? So basically what you do is the patient will sit up in a chair, and you'll just go through, you're going to look at their muscles, their facial expressions, you know, have them hold out their arms, their legs, and then you grade them on a scale of 1 to 4. So 0 being like having no symptoms, 4 being severe. And if in any category you get a 2 or higher, we're going to probably want to either stop that medication or lower the dose. So physicians use this when they start the meds, but a lot of times as nurses we have to do it too when we're assessing our patients, if you're working in a psych clinic or a psych facility. And remember, a lot of times these patients don't have anybody to advocate for them too. So if you do have a patient and you notice they get a 2 on one of those, you want to call the provider and say, hey, what you should do is use your SBAR form. Call the provider and, tell them what's going on with your patient background, and say, for my assessment, I was doing the AIMS scale and I noticed his tongue was sticking out continuously. He got a 2 on it. My recommendation is, can we either lower this medication or can we stop it? So just make sure you just know what we use that for. Here's just a little mnemonic, right? We talked about the neuroleptic malignant syndrome. So just remember. So we're going to talk about at the end of class, or a little while, serotonin syndrome. So I know both of those can get a little bit tricky. So they both have fever, they both can have confusion. But with this one, with the neuroleptic malignant syndrome, the person has muscle rigidity. Okay, so that's going to be like the difference. And so remember, this is life-threatening. We're going to stop that antipsychotic. Okay, so when we talk about nursing considerations, the biggest thing, right, is safety. So we always assess suicide risk and risk of harm to others. Sometimes you have to ask the patient multiple times, like, have you ever had thoughts of harming yourself? And maybe they'll say no, but then you'll say, have you thought of harming yourself in the past? Maybe they'll say no. Have you made a plan to harm yourself? And then they might answer yes to one of those questions. So sometimes it might seem like we're being a little redundant, but we really have to keep the patient's safety in mind. So we're going to provide that secure environment for them, very structured. We're going to set limits. And then we have to get them to trust us, right? So maintaining that therapeutic tone, right? Using their name. All right, so we want to avoid direct questions. Now, think about when you're taking a test, right? And you come to a question and you don't know the answer. How do you feel? Like you have no idea, right? So maybe like your heart starts to race a little bit, right? Maybe you get a little sweaty. Maybe you start to get angry because you're like, that teacher never talked about this. I can't believe there's it, right? And so you're starting to get angry. So think about it. So now if you ask a direct question, say you ask somebody, are you happy right now? Or are you sad? They probably don't know how they feel, right? Because they don't have any control over, right, their mood and their affect. So it's gonna make them angry and it's gonna make them feel threatened, okay? And we wanna provide a therapeutic relationship, right? We don't wanna make them feel threatened. So we're not gonna ask direct questions. Okay, so now I'm gonna contradict myself. And sometimes we do have to ask direct questions when it pertains to safety. All right, so remember we talked about the patients having hallucinations? What's the one type of hallucination that we are very concerned about? Command. Yep, so it can be auditory command, right? So if somebody says, I'm hearing voices and I've been hearing them all day, we need to ask a direct question and say, what are those voices telling you? Are those voices telling you to harm yourself? Are those voices telling you to harm one another? Because these voices, right, they are so real to somebody that they can actually carry out with those actions, right? They might be hearing something that says, you need to go kill your roommate, or you need to go attack this person. And they believe that they hear this, right? This is their belief. So again, we want to maintain that therapeutic relationship. So we don't want to say, you're really not hearing any voices. That's just going to agitate them, right? And it's just going to set them off. So what we want to say is, I understand that you are hearing voices, and that might be frightening to you, okay? We don't want to agree with them. We don't want to say, oh yeah, I'm hearing those voices too. So we want to present reality, so we can say, you know, I'm not hearing those voices, but I understand that you're hearing those voices, okay? And we want to make sure that they feel safe. In your ATI book, it made me laugh because it says, you can tell your patient to tell the hallucination or delusion to go away. Which, to me, that sounds kind of funny. I mean, you know what I mean? Because we're trying to present reality to them, but it's more like, at this point, we're gonna do whatever we need to do to keep them safe. So I don't remember a lot from nursing school, but I do remember like the therapeutic questions when we had tests. I always had a hard time with them because when you read them, sometimes they just sound kind of funny. Like sometimes it makes you think like, I would never say that. But what you have to remember was when you get these therapeutic questions, think about safety first, okay? So you know how like when we talk about biophysical, it's always airway, airway, airway. So when we're talking about mental health, we're gonna think safety, 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 okay? I know it gets a little tricky and we'll go through a bunch of questions because I think they're tough too. Sometimes they make me laugh and I'm like, I would never say that. But you would, it just sounds different when you're reading it on paper. Any questions about delusions, hallucinations, how we talk? Tolerate silences, right? So the client may be too anxious to speak. I'm sure a lot of you are nurses' aides, and I'm sure a lot of you have done one-to-ones before, and sometimes like you kind of just have to sit there, right, and just let the person be. I remember doing it, and I wish somebody had told me like it's okay to just sit there in silence and just let the person be. I mean, now you kind of see, when you see one-to-ones, I see them in the hospital, like the aide is like on their phone the whole time or whatever, right? You don't want to do that. You want to make sure that the person knows that you're there, right? And that you're there for them, but you don't have to actually make them speak. So remember that. So in a couple months, you guys are going to be RNs, right? So even though you're not going to be the one actually doing the one-to-one, try to keep your nurse's aide in a loop. It's kind of nice to like give them like a little overview of what's going on with the patient and just how to act. And by no means you're going to not have the time to give your nurse's aide a whole lesson in therapeutic communication. We'll just say, you know, just sit with the patient. It's okay to just be silent. You know, how to talk to them. Just don't forget about that, okay? We want to reduce stimulation, provide solitary activities until the patient is able to participate in group activities. Sometimes just noises can stimulate somebody and those can trigger those delusions that they have. Like I know a lot of times we're sitting with somebody, we always want to like turn the TV on and play music or like have something going, but that might be bad. So sometimes silence is better. If you start to notice that somebody's like escalating, maybe something's going on, the first thing we want to do, you know, is maybe talk to them, whatever. And if it's too noisy, we can't, maybe take them for a walk, okay? Maybe take them away from that situation. And then maybe, you know, getting them, I don't know, reading a book or getting a little activity that might distract them from what's going on. We want to avoid any competitive activities, right? That might just cause some agitation and anger as well. I don't know if you guys, can you guys read this? I'll read it too. So you're working on an inpatient psych unit. You're going to do an assessment on RB, who has just been admitted. He has a diagnosis of schizophrenia. He's 22 years old and has been attending the local university and living at home with his parents. He has always been a good student and has been actively social. Last semester, his grades began declining and he became very withdrawn. He spends most of his time alone in his room. His grooming has deteriorated. He can go days without bathing. For several weeks before admission, he insisted on keeping the blinds and curtains in the house closed. For the past 2 days, he has refused to eat, saying they've contaminated the food. And as you approach him, you note that he appears to be carrying on a conversation with someone, but there's no one there. When you talk to him, he looks around and answers in a whisper, but gives you little information. He states, "They are watching me and told me not to cooperate." Okay, so when we go back to our symptoms, right? So what's a negative symptom? So negative, right? So negative is going to be those depressive symptoms, right? So do you see any negative symptoms there? Yep, social withdrawal, blinds closed. Great. All right, so remember, what about the positive symptoms? Those, right, so those things that shouldn't be there, right? Those hallucinations and delusions. All right, so we talked about that. So remember the terms too. So he's exhibiting like abolition, so that's no motivation and attention. And we talked about he's having those delusions of reference and persecution. Okay, so what do you think? What's going to be our most important thing to treat him? What could be our most important intervention? Safety, keeping him safe, right? Maybe keeping those around him safe. What else? What else? Yep, asking him, right? Let's see what I said. All right, so protecting him from self, creating a supportive and structured environment, supportive and directive communication, making sure he feels safe, right? And then maybe, so he's just diagnosed with schizophrenia. We have to check and see like what medications is he on? Does he need to be on new medications, change his medications, and go from there. All right. A nurse is speaking with a client who has schizophrenia when he suddenly seems to stop focusing on the nurse's questions and begins looking at the ceiling and talking to himself. Which actions does the nurse take? So I'll let you guys read through those for a second. What do you guys think? B, right? Right, so you're gonna ask the client, are you seeing something on the ceiling? You wouldn't stop the interview, right? That wouldn't make sense. Tell the client you seem to be looking at the ceiling, I see something there too. No, because we wanna present reality, right? That'll just push them farther into their delusions. We don't wanna continue the interview without comment on the client's behavior, right? That's not therapeutic. A nurse is caring for a client who's experiencing auditory hallucinations. The client states, "The voices won't leave me alone." Which of the following statements by the nurse are appropriate? All right, so select all, so let's go with it. How about, when did you start hearing the voices? Is that true? Yeah, we're gonna say that. The voices are not real, or else we would both hear them. No, because that's almost mean to say, right? We're not gonna say that. How about, it must be scary to hear those voices? True, right? Because we want to validate the patient's feelings. How about, are the voices telling you to hurt yourself? Yes, we need to know. We need to make sure they're safe. And how about, why are the voices talking only to you? No, right? The patient doesn't know that, right? That's false. That sounds like threatening. I'm not gonna do that. A nurse is caring for a client on an inpatient health unit. The client reports hearing voices that are telling her to kill your roommate. Which of the following actions does the nurse take? All right, so tell the client that she is imagining voices. No, I'm gonna do that. Initiate a one-to-one observation of the client. Yeah, right. We're not gonna place the client in a restraint. We're definitely not gonna ask another client to sit with the patient. So we always want to do like the least restrictive measures first, but to make sure that everybody's safe. A nurse is completing an admission assessment for a client who has schizophrenia. Which of the following findings does the nurse document as positive symptoms? Select all. So how about an auditory hallucination? Is that a positive symptom? Yes. How about lack of motivation? No, that's a negative. How about use of clang associations? Yes. How about a delusion of persecution? Yes. How about constantly whipping arms? There's a little yeah. Yes, right? So that's something present that wouldn't normally be in a healthy person, right? How about a flat affect? No, right? That's negative. All right, a nurse is assessing a client who recently began taking haloperidol. All right, so now when you see this, you see the med. What kind of med is haloperidol? What generation? First generation. So remember that slide, first generation. All right, which of the following findings is the highest priority to report to the provider? There's shuffling gait, neck spasms, drowsiness, anticholinergic effects. Yeah, so okay, so neck spasms, right? So remember we talked about that dystonia, right? So that could lead to respiratory distress. Shuffling gait, right? It is a problem, right? Because the patient could end up falling and be at risk for fall. But we're more worried about breathing right now, okay? Drowsiness, right? That's nothing. Anticholinergic effects, that could definitely happen, but that's not life-threatening, okay? All right, are you guys good? Do you need a break? Do you want to keep going to bipolar? Good? Keep going? Okay. So now we're going to talk about bipolar. And when we talk about bipolar, we have bipolar 1, bipolar 2. So bipolar 1, we're going to talk about patient has lengthy periods of mania. So, right, so overly excited, so much energy, and that can actually lead to like a hospitalization, okay? And then that's mixed in with depression, right? So they can go from highs to lows. And then bipolar 2 is hypomanic episodes that alternate with depression, right? So the difference between hypomania and mania, hypomania isn't really life-threatening, right? So they feel on top of the world. They just will walk into a room and be like, I feel great, everything's wonderful, isn't life great? And that they don't usually end up getting hospitalized for that. They're not like a threat to themselves or somebody else. But they don't know what to change in them, but somebody around them would. So somebody's like close family member might say like, yeah, they're not acting like themselves. So that's how like doctors diagnose between bipolar 1 and bipolar 2. So they either have that totally like manic episodes where they can go days without eating, days without sleeping, or that hypomania where they just have this overly excited mood, this grandiose feeling with that hypomania. So usually the first manic episode generally occurs between teenage years, 30 years old. So there's a lot of clinical manifestations here. I know it looks a little overwhelming, but they all kind of flow together. So when we talk about those manic clinical manifestations, they start, right, they can start all the way. Sometimes like no trigger, they can just happen. And all of a sudden like their symptoms escalate and they can last anywhere for a few days, for a few weeks. They feel great. They can have an almost promiscuous behavior, attention-seeking behavior, can get agitated very easily. They have a lot of self-esteem, right? They feel they're very overly confident. Sleeplessness. So we all say like all the time, like, oh, I haven't slept in days. Sometimes when somebody's in a manic episode, they can literally have not slept in days, like not slept 1 minute, to the point where it's like an emergency. Like they can actually like keel over from exhaustion, and that's life-threatening. Pressured speech. Do you guys know what pressured speech is? So talking really fast, you cannot get a word in, you cannot interrupt them, you cannot change their train of thought. They are just going and going and going, okay? And that kind of goes along with our flight of ideas, and then they're going from one place to another, kind of like what we talked about this with the positive symptoms of schizophrenia. High-risk activities, poor judgment, being very impulsive, that increased energy, so much increased energy that they're just going and going and going, and they don't even stop to eat. Like they might not have, they've had poor nutrition, haven't eaten in days. And then it can get to the point where they have a possible presence of hallucinations or delusions. So you see there's kind of like that overlap with schizophrenia as well. And then the depressive manifestations, right? It can kind of usually gradually slide into that state, right? So they may not get out of bed for weeks, maybe months. Showing no emotion, crying, right? Inertia, no energy, right? They don't feel any pleasure, don't feel happy, can't concentrate. Self-destructive behaviors, we gotta remember keeping safety, decreased appetite, disturbed sleep, psychomotor issues as well. Okay, so lithium. Lithium's a mood stabilizer, and it's been around forever. It's been around since like the 1960s, okay? You do need to know the therapeutic level, okay? It's always been an NCLEX question forever. So the therapeutic level is 0.6 to 1.2. So the problem with lithium is that somebody can become toxic if their level gets above 1.5. See how there's such a little narrow window? So 1.2, they can be therapeutic, and just a couple points up, they can start having issues. So we need to, first of all, make sure our patient is going to their scheduled lab work. So when somebody first starts is get put on lithium, they'll go every couple of days while we're checking their levels. And then after that, it's usually like every couple of months. We'll be checking. We have to make sure that they stay consistent with their lab work. But what we need to do is to teach them to watch out for signs of toxicity. So it gets a little confusing because there's some of the adverse effects that can just happen that even when they're therapeutic, you can have some nausea, vomiting, right? So everybody has nausea, vomiting with every med, it seems like. That can be a side effect. We need to teach them first. You need to take lithium with food, okay, to try to prevent that. A possible side effect too, before, like if they're therapeutic, they can have some tremors. So sometimes the doctor might order, remember we talked about before with the akathisia, they might put them on a beta blocker along with it if they're just having some little bit of tremors. So even if, say it's a Tuesday and your patient went for lab work and their lithium level was 1.0, say they're fine. And then the next day, on Wednesday, they wake up and they notice a little bit of a tremor. We want to teach them, you know what, even though it's just a minor side effect, call your doctor. We're going to get you in, like, he'll get you in for lab work because we want to stay on top of it. So in your ATI book, so there's a little bit of discrepancy, like in the books. In your ATI book, it says, like, so from 1.5 to 2, these are the symptoms of when somebody has toxicity. 2 to 2.5, these are the symptoms. But it's a little bit, I don't want you to know, like, I don't want you to separate it like that. I just want you to know all the generalized symptoms. Because somebody's level could be 1.5, and they might have a seizure, even though, you know what I mean, you could have any of these symptoms. So we just need to be aware of it. The way I have them listed out, though, is kind of what, like, is what happens first, usually, but not always, and then it kind of goes down all the way to possible death, so like myocardial infarction. Ataxia, what's ataxia? Loss of coordination, right? And like loss of coordination, slurred speech, so it almost looks like the person's intoxicated, okay? So we want to teach them, our patients, like, if we see any of this, we need to stop the lithium, right, and get a level done right away. So if you see it kind of go down and you see all your levels, so oliguria, what's that? No urine, right? So if somebody gets to the point where all of a sudden, they're not able to make urine, they're not peeing, they actually can wind up needing hemodialysis, okay? So we want to try to make sure, right, like we're checking their levels all the time. So there's a lot more, a lot more to it than that. So when we talk about diet considerations and stuff, lithium's a salt, okay? This is where it gets a little confusing. Lithium's a salt, but we want to teach our patients to maintain an adequate salt in their diet. We don't want to restrict their salt. So if somebody starts, they're on lithium, and then maybe, I don't know, whatever, they start thinking that they're gonna decrease their salt, the body ends up absorbing that lithium even more, and that can lead to toxicity. Okay, so that's where it gets a little bit confusing, all right? So maintain an adequate salt in your diet. So we don't want them to increase their salt, because that's gonna wind up more bombs, okay? Maintain adequate, just keep doing what you're doing. So if you think about it, so with this med, would we be able to give this med to somebody with CHF? No, right? Because they're already on a low sodium diet. If you think about across the lifespan, right? I mean, you guys are all in clinical now, doesn't it seem like as everybody gets older, like everybody has like heart failure or some degree? So that's when it starts to get a little tricky. So say somebody has been on lithium their whole lives, right? And so lithium's really good at smoothing out the highs, smoothing out the lows, right? Keeping that balance. And now they develop heart failure. What do you do? What do you think? Maybe they probably are going to have to change the med, right? Same thing. So we actually need to they need to drink a lot, okay? Like 2 to 3 liters of fluid minimum. That's a minimum, okay? So same thing. We can't give it to somebody who's CHF. It's not going to be good for patients as they get older. So same thing we talked about before, maybe teaching our patients to keep a water bottle with them at all times. And it does make you thirsty too. It makes the patient thirsty, so they're going to want to drink, and we got to teach them that that's okay. It's also going to, all right, so they're drinking a lot, so it is going to make them urinate a lot too. We got to teach them that's okay. Sometimes though, so see how it says excessive output of dilute urine. So if they're peeing a lot, that's fine. But all of a sudden it seems like even more than usual, we need to teach them to report it as well. I was working once and there was a patient who was on lithium and the nurse's aide brought him, a pitcher of water and like he drank it in 2 minutes. And he's like, "Can you fill this up again?" He said to the aide. And the aide looks at me and she goes, I just filled this up. What can I do? Should I give him another one? Like, yeah, it's okay. So we need to teach like our nurses' aides or whoever's working with the patients that it's okay to give them as much water as possible. Obviously, if you're in like a psych facility, that's okay that they know about it. But think about if you're on a tele floor, right? If you're like in acute care, doesn't it seem like almost everybody's on a fluid restriction? So that patient might be asking for water, and he's like, "Yeah, I drink pitchers and pitchers of water." And they're like, "No, we're not going to give you, but we do. We need you to keep bringing in pitchers of water." So one thing you can do is maybe bring in a couple and just line them up for the patient, right? Because a pitcher is like 500 mLs. That's only a half liter, and they need to be drinking at least 3, so you can line them up with a bunch of water. Yeah, you'd want to do I's and O's too, because we would want, like we said, we would want to make sure they're not having now excessive output of dilute urine. Yep. So I's and O's, probably daily weights as well. Make sure they're not retaining fluid. We also, yep. So yeah, so it can be a sign of both. So it's an adverse, that's where it's confusing. It's an adverse effect, so tremors can happen, right, when somebody starts the med. So we're gonna let the provider know. So say person starts the med, they develop a tremor. We do a level, and their level's 0.8. So the doctor's okay with it. So he might put them on a beta blocker to go along with it. Yeah, but how do you know, right? So how are you gonna teach a patient? So you're gonna say to your patient, if you have a fine tremor, that's okay, don't worry about it. But if you have a coarse tremor, please call your doctor. Who knows, how can you differentiate? So I say just better to be safe, right? So we're gonna just say to the patient, if you notice any kind of tremor, it's better to come get checked out, check a level, and yeah, because that is confusing. I don't like that either. I would just say, come get checked out. We want to make sure, we want to teach our patients no going outside and doing anything that causes excessive sweating, right? So think about it, right? You're sweating, you're going to lose that salt in your body and all that fluid, and it can actually lead to toxicity as well. Okay, so we want to avoid any activity so if you see a lot of this has to do with the kidneys, what the kidneys are doing. Before they start, we're going to get a baseline BUN and creatinine, just to make sure so we can keep an eye on their kidney function as well. Remember, your kidneys and your heart go hand in hand too, so probably we'll get a baseline EKG and we'll follow that because we want to make sure, right? So, if your kidneys aren't working, your potassium might get higher. That could lead to dysrhythmias, so it all kind of goes together. So kidneys and heart always go together. Some people who have been on lithium long term, they can develop like a thyroid goiter. So we're just going to keep track of thyroid levels as well too. We'll get a baseline and they'll get that checked out every once in a while. Any questions about lithium? Yeah. Yes, that's really, yes, perfect, yep. So if somebody's level is 0.4, they're probably going to be showing some signs of mania. Yeah. That's a good question. So that's another teaching point. It's kind of hard to say. So you can't say to your patient, if you feel like you're manic right now, come get checked out. We'll check. Maybe teaching family member around them if they're living with family. Obviously, if they're in a psych facility, we're assessing them, we can watch them and notice if they're starting to be manic, maybe we need to increase their dose a little bit. But also just teaching family is huge too. Okay, so some more meds that we use are anticonvulsants. So anticonvulsants came into play. Researchers found that if they started anticonvulsants with the lithium, they could go a little bit lower on the lithium dose. And now it kind of seems like anticonvulsants are maybe more the way to go. It seems like we're using those more and more. Does anybody work in a psych facility? No? Does anybody see meds? Yeah. Do you see more? I think it's more anticonvulsants, right, that what we're seeing. So if you think about it, anticonvulsants, they decrease that hyperactivity in the brain. So it's going to help, it's going to decrease that, right, for people with manic symptoms. And it can also help a little bit with the depressive symptoms as well. So valproic acid is the one that you need to know. The therapeutic level is 50 to 120. Now, I don't know if you guys remember, but whenever you did seizures, right, back in 2005, you probably learned about this med. And I'm assuming you learned the level 2. The level's a little bit different. So the therapeutic level to maintain for seizures is 50 to 100. But when we're talking about for bipolar disorder, we bump that up a little bit more to 50 to 120 because that helps with the mania a little bit more. So some things with photosensitivity. So do you guys remember Steven Johnson syndrome? Learning about that, right? They get that really bad blistery rash. That is an adverse effect. It goes along too with carbamazepine. You'll see that more there. The big thing that I want you guys to remember for the adverse effect for valproic acid is hepatotoxicity. What does HEPA mean? Liver, right? So if somebody's on valproic acid, what levels are we going to look at? Yep, right, your LFTs, okay? So we're going to get a baseline LFTs, and throughout the course, while they're taking the med, every couple of months, we're going to check their liver labs, right? Their ALT, their AST, and we're going to look at that. So what are some signs that your liver isn't working? Jaundice, right? So that yellow of the skin, if you notice that, we're going to look at their labs, right? Or if you notice any yellow around the sclera, check their levels, right? It's more nausea, abdominal pain, that could all be a problem. Check their levels. What does it mean, bone marrow suppression? Yeah, right, so yep, decrease. Your body's not making red blood cells, white blood cells, platelets, right? So they could possibly be anemic. Platelets are low, right? So thrombocytopenia. White blood cells are low. Again, risk of infection, right? So we're going to teach them if they have any signs of infection, sore throat, fever, let somebody know. They're going to be on bleeding precautions. So we gotta let them know, right? If you notice an increased bruising, bleeding gums, we need to get your levels checked as well. So along with the anticonvulsants, those antipsychotics that we talked about back with the schizophrenia, they might use those too to help out. Depends. Remember we said with bipolar, they can have maybe manic, those delusions, hallucinations. We might need to put them on an antipsychotic as well. And then also, we might use an SSRI, right, to help with those depressive symptoms. And that's when you have to monitor for that serotonin syndrome. Okay, so just put this there so we can kind of differentiate. So it's kind of like the neuroleptic malignant syndrome, except this is with the SSRIs. So this one, the little difference though also is this comes on suddenly, right? Within like a few hours of starting the SSRI. and they have that hyperreflexia. Same thing, fever, medical emergency, but in this case, we're going to stop that SSRI if this happens. Okay. So we're going to talk about a little bit about electroconvulsive therapy. So this is when the patient is really severely depressed. They've been on medications, they're not working, they're probably suicidal. It doesn't work for patients, patients with substance abuse or personality disorders. We only use it to treat severe depression. You definitely need informed consent, but if you think about it, do you think this patient could give informed consent? They're probably not in the right state of mind, so you can get it from their healthcare proxy. So the patient will get a short-acting anesthetic and a muscle relaxant. And then the doctor will put electrodes on their head, and it almost stimulates a little seizure activity. The big thing with the ECT therapy is there's a big stigma, and that people think maybe, I don't know if you've ever seen it in any movies or whatever, it's sort of portrayed like it's painful, and that it almost looks like a torture device, but it's not. So they're able to now to basically just relax the muscles so that they're not having a full-out clonic seizure. So it's the nurse's role, right, to educate your patients about this. If you're involved with this, you're going to be taking vital signs throughout the procedure. The patient's going to get oxygen during the procedure and after. They are at a slightly increased risk for heart issues, so they're going to get an EKG right before. We'll be cardiac monitoring them. And then when they wake up, they will be a little bit confused, and they're not going to remember the procedure, so they might have a little bit of short-term memory deficits, but it'll come right back. Okay? So we just need to educate them for the most part. Some people think, if they get this done, it's going to wipe out all their memories, or they're going to be confused forever. So it can be done at an outpatient procedure. Can't drive after, but then they go to recovery, and once they wake up and that anesthesia wears off, we're good to go. Let me see if I can play a little bit for you. I was having technical difficulties before. Okay, so there's Peter. We have the physician over there. I'm going to fast forward just a little bit so you can, I want to get to the part of this here.
That was a shot. He was having a seizure.
So that's just the seizure right there.
We isolate this hand by using a tourniquet in the wrist to keep the hand from being paralyzed, so we can monitor the seizure with convulsive activity in the hand. Since we paralyze the rest of the body, it protects against risk of injury.
So that was the end, right? So it's not so bad. So say your patient is on like a benzodiazepine, right? Say they're on Ativan. Would you give them the Ativan before this? No, right? So you want to hold any like seizure medications before, right? Because we want to induce a seizure. No, I mean, maybe it could, but now they've gotten the technology like so right, and it's just, they do a very mild shock that, no. Okay, so when we talk about our nursing considerations, it's kind of basically the same as when we were talking about our considerations when we're working with schizophrenic patients. Basically providing safety, assessing suicide. What we want to do though is sometimes patients, especially when they're in a manic state, they can be a little manipulative, right? So our first thing we want to do is we're going to set verbal limits, okay? So say you're in a group therapy activity room and somebody's talking out and they're being threatening. The first thing you want to say is, you do not tolerate this here, okay? You want to tell them that's not okay. If you speak like that again, we're going to take you out, okay? So be very direct. And then you go to the next step. So if you set limits and they're still, maybe being threatening or whatever, we're going to take them out of the situation, okay? Maybe go have someone sit with them in another room. Sometimes we do have to go to seclusion, right, and have them just stay in a room by themselves if they're being really threatening. And then after that, we would go, if really violence and somebody's safety is at risk, we would then go to restraints after that. Same thing, right? Quiet. Try to avoid anything like no loud TVs. We're going to monitor for escalating behavior. I also want to talk a little bit when we talk about like that structured environment. We're going to actually do those group therapy, sessions as well. Do you guys remember cognitive behavioral therapy? You talked about it during addiction way back when. And that dialectical behavioral therapy. Okay, so that's going to be involved with all this, and that's in that really nice structured environment. We're going to teach them those coping mechanisms, how to change their way of thinking, right? Change their thought processes and the ways that they react to things. And then also just keeping it consistent, trying to keep the same staff with them, making them feel safe and secure. Remember we talked about how these patients, sometimes they don't sleep. So in the hospital how we don't let people sleep ever, and we wake them up in the middle of the night to take their vital signs and take their blood pressure. People with mania or in a manic state, we really don't want to wake them because they can go days and days and days without sleeping. Okay, so once they go to bed, make sure shut off all the lights, keep it quiet. We're not going to wake them for any reason. And sometimes they have these major sleep disturbances where they're waking up and they want to come out of their room and just talk to you all night. And we don't want to ignore them, but we want to promote that restful environment. So if you think about it, it's kind of like when you're sleep training a baby, right? When the baby wakes up, you don't go and you don't flick on all the lights and you don't make a lot of noise. So then we just redirect them back to their room, keep it quiet, and we want to make sure they get that sleep that they need. We almost have to teach them, again, how to do that. Sometimes they don't eat, right? So somebody in a manic state with all that energy and they're just pacing back and forth, same thing, they can go days and days and days without eating. So we're going to give them whatever food we can give them that they're going to be able to consume. So they're not going to sit down and eat a bowl of soup, right? That's not going to be useful to them. So providing like finger foods that they can just grab and then keep walking, because we want to make sure that they're getting some nutrition there. All right, a couple things. So I'm going to pass around, this is a quick little case study for you to do. It's going to take you like 5 minutes, okay, to do. You guys can work together, work by yourselves, whatever. See if you can it's a little test your knowledge. So see if you can do it without looking back at your notes, right? This is going to be a good study guide for you, right? Because your test is coming up. So I'll pass it around. I'll give you guys like 5 minutes to do it. If you need to take a little break, you can. Over there, if you want to grab it during break 2, There's an ATI review book and a white folder, and that's just for your ATI review in a couple weeks. So just take one of each, because there's only one for everybody to go around. So you can take a pink book and a white folder, and then I'm going to pass these. If everybody could just take one and pass them around.
Monday and Thursday, Monday and Tuesday.
Squeeze. Thank you. Actually, do you know what app store is? There's like this other app. Thank you. There's another thing called ATI Board Vitals. So it's like board.
Oh, I've seen
Did
that.
you click into it?
No, I haven't.
So it's basically when you click like what categories you want to do, and it's like the questions are like so not like 18.
Okay.
So I was doing it on the weekend. Yeah. Well, I haven't done it yet. It's too expensive. You paid for it. For 3 months. See, I was trying to wait until like after final even just to sort of focus on that. But this was so much easier. I'm like, you can click what you want and it shows you the rationale and how many people got it right or wrong.
Okay, exactly.
Every conversation I have, like, just like documenting them. Just like literally waking up. Right. Every. Water bottle.
Everybody have the sign sheet over here? Everybody have a question sheet?
Yeah. No, yeah. Also, what I so this is when you're looking to read 505 dollars. So what's it? The cheap stuff that
You
and that's the thing, I think
for us,
So I did. Thank you. Nice.
see, it was only like
that was not
I
early.
was like 2 times studying, but I was like, let me just
I
get
would
paid
say,
technically.
so mine
Because I'm trying to figure out the virtual.
I would like work.
So it is, I was like, let me just see what this is. This came up on it.
Like, I'm putting it on, like, if I can work full time.
Yeah, so that's that.
On the outside. So I was like initially planning on taking like first week of July or like and last week of June, so that I could work like on I don't know if they'll like hire me right away. I think they will, but I don't know if they're gonna like keep me as a nurse until I start my class, which they did really good because I didn't hear she started her bachelor's program. And they told me that that was a good option. You're enrolled in the bachelor's program, and so I already have a professional nursing, or they already have the 18 credits that I need to take the professional courses. I don't know if they're gonna still make me pay for their enroll still that. Because I'm already technically like accepted.
So I printed it on that, but an app. So I didn't want to say anything, right?
I always get yes,
Yeah.
For like,
I would probably just like early in the day, yeah, probably be perfect. But no, like I think mine was actually I thought I but I feel like
She changed her date.
really
Her date is later.
pushed it back. Like pushed it back earlier. Yeah. I my whole so I'm moving hours. So I was moving to Mars. And so I don't know, my goal was like if I work in June, like the same one as and then back and forth. I would probably well, my husband was I need to talk to my boss this week. I'm gonna like try and have a meeting with one of the supervisors. And be like, hey, and so I have like a solid plan so I can move forward. I want to know when I'll be able to stop
All right, you guys ready? Go answers. All right, so what information would we want to get from the patient, right? She said hypomania in the past, bipolar type 2. What's an idea? Safety questions. Yep, always safety. Any other ideas? New here? Sleep patterns? Yep. Yep. Is she eating? Good. Yeah, has she been taking her meds? That's good, yeah. All right, so some ideas. So we said, how many hours is she sleeping at night? Are her thoughts racing? What kinds of activities is she involved in? Right? So it said in the case study that she was hypomanic. So a lot of times, remember, people don't realize that they have this hypomania. So are other people commenting that she's acting differently? So maybe you could get information from her husband, right? You'd want to make sure that being compliant with that. You want to look at her body language. How is she racing around? Is she all over the place? Is she able to sit still? And we talked about food and also sleep. Okay, so we talked about the difference between hypomania and mania. Right. Okay. So it doesn't cause. We want to just remember with the hypomania, it doesn't cause as significant impairment as mania does. Okay. So mania, they can be indicators themselves. Okay, so when Esty started her lithium dose, she would have cautioned to report side effects. So this one I think is the trickiest one, right? When we're talking about side effects versus toxicity. So what did you guys get? What do you think? Thirst? Yeah, or a little bit of everything. So thirst, nausea, and tremors. Okay, so those are those common side effects, right? Dizziness and constipation are one of them. So even though these are common side effects, right, but we're still going to have to report them, okay, just to be on the safe side. Okay, so now we'll talk about lithium toxicity. So what other more symptoms now when we're talking about toxicity? Lethargy, vomiting. Yep. So there's diarrhea, lethargy, vomiting. Okay. Shortness of breath, that's not one. We can talk about that, not insomnia. Okay, so what about 1.0? What are we going to do? Nothing, right? So we're just going to keep the dose the same, okay? That's what their normal limit is. If it was less than 0.6, right, she'd probably be manic. So what kind of lab and testing should be routinely performed? UN, creatinine, thyroid, or to say, right? And then remember that cardiac testing too. We're going to get EKG once in a while. All right, so what instructions are you going to tell her? Yep. Adequate sodium and fluids. Go to your lab work. Yes, very good. So maintain adequate hydration, right? Especially when perspiring. Know the symptoms. If there's any symptoms, if you want to tell them to hold that next dose and call the doctor. Okay, so we don't want to have them like abruptly stop the med, but if anything's happening, just wait to take that dose, call the doctor, and we'll see what happens after that. That adequate sodium in the diet, and make sure you go to your lab work. So what other meds could we use to treat bipolar? Intake of Molsons, yep. Yep. So, we have the Depakote, Tegretol, the Pluvicto, and any of those antipsychotics we talked about, risperidone, olanzapine. Okay, so use the teach back after you taught her about lithium. Which one of these statements would say that she needs further education? B, right? It's not addictive. So this kind of goes along, so I want to mention with all of, we talked about antipsychotics too, none of them are addictive. So a lot of times patients are going to say like, I don't want to take like my antipsychotic or I'm not going to take my lithium because I don't want to get addicted to it. That's false. So we want to teach them that no, they're not addictive. So what are some interventions that you can teach her how to minimize those mood swings? Sleep, yeah. Nutrition. Coping mechanisms, yep. Very good, yep. Yes, definitely. So avoid, you can't, how do you avoid stressful situations? But maintain sleep and exercise, healthy diet,